Welcome to The Explainer. Today we are pulling back the curtain on one of the most complex challenges in all of medicine, lung surgery. We're going to go inside the operating room to really understand the incredible balancing act that anesthesiologists perform every single day. So let's just jump right into the biggest question, right? It's the central paradox of the entire procedure. For a surgeon to do their job, they need the lung to be totally still and deflated. But the patient? Well, they kind of need to breathe. So how on earth is this even possible? Let's unpack the really ingenious strategies that make it all work. You see, the surgeon's need for a collapsed lung creates this immediate, high-stakes problem for the anesthesiologist. Their number one job is to keep the patient safely oxygenated and breathing. So they have to figure out a way to take one lung completely out of commission while somehow making the other lung do the work of two. And the solution to this puzzle is a technique called one-lung ventilation, or OLV for short. This is really the cornerstone of thoracic anesthesia. It's this deliberate, carefully controlled process where we isolate the lung that's being operated on, we let it collapse, and then we direct all the airflow to the other healthy lung. Now, to do this safely, you need some very specialized tools. The real workhorse for this is something called a double lumen tube, or a DLT. Just think of it like a breathing tube that has two separate channels built into one. One channel goes into the right airway, and the other goes into the left. It's a brilliant design because it lets us ventilate each lung on its own, or, more importantly, turn one lung off while keeping the other one working just fine. There are other options like a bronchial blocker, which is kind of like a tiny balloon that blocks an airway, but for most adults, the DLT is the go-to standard. Now, putting this tube in is a task that requires absolute precision. It's not just about getting it into the airway, it has to be positioned perfectly. After it passes the vocal cords, it's rotated just so and advanced to exactly the right spot. And you can't guess. The final position has to be confirmed visually, using a flexible fiber optic scope to actually look down the airway and make sure it's perfect. This precision is so critical because, as we're about to see, solving one problem in lung surgery often introduces a whole new one. Okay, so we've collapsed the lung for the surgeon. That's great for them. But now we've created a new physiological puzzle. You see, blood is still flowing through that collapsed lung, but since there's no air in it, that blood isn't picking up any oxygen. That oxygen-poor blood then mixes right back in with the oxygen-rich blood from the working lung, which can drag the patient's overall oxygen levels way down. This effect is called a shunt, and believe me, it is not a small problem. We're talking about up to 30% of the blood from the heart being shunted through that non-working lung. That creates a really serious risk of low oxygen levels, or hypoxia. But here's the fascinating part. The body has this brilliant, totally automatic defense mechanism against this exact problem. The body's solution is a remarkable reflex called Hypoxic Pulmonary Vasoconstriction, or HPV. What happens is, the blood vessels in the parts of the lung that aren't getting any oxygen just automatically squeeze down. It's incredible. This constriction shunts blood flow away from that useless collapsed lung and redirects it over to the ventilated lung where it can actually pick up oxygen. This natural process is a critical safety net that anesthesiologists absolutely rely on. So just getting through the surgery safely is really only half the battle. After that, the anesthesiologist's focus completely shifts to protecting the fragile remaining lung tissue and preventing any post-op complications. And a major one they worry about is atelectasis, which is just the partial or complete collapse of the lung after the surgery is over. You can't just blast that remaining lung with huge breaths of air. You have to be gentle with it. Anesthesiologists use what's called a protective ventilation strategy. This means using smaller, gentler breaths, applying just a little bit of positive pressure at the end of each breath, we call it PEEP, to keep the tiny airways from collapsing shut, and also limiting IV fluids to keep the lung from getting swollen or waterlogged. It's all about minimizing the stress on the lung that just had to do double duty. And preventing that lung collapse is a real team effort that starts way before the patient even gets to the OR. Quitting smoking for at least 4 weeks beforehand is huge. Pre-op physiotherapy helps strengthen the breathing muscles. And then after surgery, excellent pain control is key so the patient can actually take a deep breath and cough effectively. After that, things like breathing exercises and getting the patient up and walking around are absolutely vital to get that lung fully opened back up. All right, let's talk about pain. Because a thoracotomy, that's the incision they use to get into the chest, is known for being one of the most painful incisions in all of surgery. And managing this pain isn't just about making the patient comfortable. It is absolutely essential for a safe recovery. I mean, think about it. If it hurts too much to take a deep breath, you're just not going to do it. If you can't cough to clear out secretions from your lungs, you're at a huge risk for developing pneumonia. The pain itself becomes a direct barrier to recovery, putting the patient at a much higher risk for serious lung complications. That's why aggressive pain management is completely non-negotiable. The approach here is multimodal, which just means attacking the pain from a few different angles at once. But the real gold standard is the thoracic epidural. By placing a tiny little tube in the back, we can drip numbing medicine directly onto the nerves that supply the incision, blocking pain signals right at their source. This gives such profound pain relief that studies have actually shown it directly reduces lung complications, especially in patients who are at high risk. So far, pretty much everything we've talked about relies on general anesthesia and a breathing tube. But what if, for some patients, we could avoid all of that? It's a technique that's really gaining traction, and it's known as non-intubated or awake thoracic surgery. By using really powerful regional anesthesia, like that same thoracic epidural we just talked about, some patients can actually stay awake and breathe completely on their own during the entire surgery. This avoids any potential injury from the ventilator and can lead to less inflammation, a faster recovery, and a shorter hospital stay. Now, it's not for everyone. You need a cooperative patient and a shorter, less complex surgery. But for the right person, this represents a major step forward. You know, all of these techniques, from the one-lung ventilation to the awake surgeries, they all come back to one core philosophy in thoracic anesthesia, and it's summed up by this Latin phrase, "Don't burn your bridges." It means you never commit to a step you can't reverse. You always maintain a path back to safety. You always protect the patient's ability to breathe. It's this constant dynamic assessment of risk and physiology. The real question is, as these techniques get even more refined, just how far can we push the boundaries of what's possible inside the chest?